Hello, it's a pleasure to talk to you today. I wish we could do it in person. It's my purpose to talk to you about advancing cancer screening's contribution to cancer control. These are my disclosures. I work for Johns Hopkins University. I do some consulting for the U.S. government. In addition, I wrote a book a few years ago for which I collect royalties. The talk today has nothing to do about the book, but I really think I should disclose it. Worldwide cancer death rates are declining. This is due to prevention efforts, use of effective screening, and improvements in cancer treatment. Screening is doing a test to determine if cancer might be present in an asymptomatic individual. Most distinguish mass screening versus screening within the physician-patient relationship. Diagnostic tests are used when there are symptoms that cause a clinical suspicion of disease. Finding disease is not a measure of success in cancer screening. Increased survival is not a legitimate measure of success outside of a randomized clinical trial. Reduction in mortality is the only true proof of effective screening, and this requires a randomized screening trial. There are several examples of cancer screening tests that have found localized disease, increased the amount of disease found, increased the proportion surviving 5 years, and possibly increased risk of death. Some studies that have shown screening not to be effective, but found localized disease and increased the amount of disease, is urine screening for neuroblastoma and chest X-ray screening for lung cancer. Screening can be both beneficial in that it saves lives, and it can be harmful. The worth of screening is really measured in a benefit to harm ratio. And this is usually determined with large prospective randomized trials. Screening is subject to several biases, among them lead time bias, length bias, and overdiagnosis. Lead time bias is shown to us in line B here. It's the concept that screening finds disease earlier. Now, one has true lead time bias without benefit in line B, where the patient is found to have disease earlier, lives longer knowing that they have disease, so survival from diagnosis to death increase. But death occurs at the same time it would have occurred without the screening. When screening is beneficial, it's as if it's line C. There is a lead time bias, but the patient lives longer than they would have lived without the screening test. Because of lead time bias, survival can increase without a decrease in mortality. Indeed, both survival and mortality increased in randomized trials of chest X-ray and sputum cytology in the 1970s. Biologic behavior is a key to its screenability. Slower growing, less deadly tumors are actually easier to find, treat, and cure. Fast-growing cancers don't benefit from screening. There are some small screen-detected cancers that are not a clinical threat to the patient. We cure some cancers that don't need to be cured. How to determine that these tissues are non-threatening is a major area of research and involves genomic analysis of the tissues. One example of overdiagnosis in cancer is the thyroid cancer screening experience in South Korea. In 1993, the incidence rate of thyroid cancer in South Korea was 5 per 100,000. The death rate was 4 per 100,000. The next year, a massive campaign to screen with ultrasound was started. By 2011, the incidence of thyroid cancer in South Korea was 75 per 100,000. The death rate was 4 per 100,000. In the United States, We calculate that overdiagnosis occurs in 10 to 20% of lung cancers found through screening, 10 to 50% of breast cancers found through screening, up to 80% of DCIS found in breast cancer screening, 40 to 60% of thyroid cancers, and 60% of screen-detected prostate cancers. We're truly moving from a 19th century definition of cancer to a 21st century definition of cancer. The 19th century definition involved the biopsy. The 21st century definition involves the biopsy and genomics and realizes that some cancers are so slow growing, they're not a threat to the individual. Examples of genomic tests that help us in breast cancer are Oncotype DX and Mammoprint. Now, the gold standard for figuring out if a screening test saves lives is the randomized trial, where a group of individuals are randomized to group A or group B, where one group gets the screening test, the other group does not, and the death rates of the two groups are compared over time. These tests or these studies are large and they take years to do. And they're very difficult to do. Well-designed clinical studies have suggested a mortality reduction through mammography for breast cancer, prostate-specific antigen screening for prostate cancer, stool blood testing or sigmoidoscopy for colorectal cancer, pap smear screening or visual screening of the cervix for cervical cancer, low-dose spiral CT screening in those at high risk for lung cancer. It is of note that there is no prospective randomized trial that has shown that colonoscopy saves lives, but we all accept that it does. Too often, screening is looked at as a one-time event. Screening is really best done in a program in which the patient is followed over time and reminded to get regular routine screening. In the case of things like mammography, it's important that old mammograms be available for comparison. Let's look at breast cancer. Routine mammography is recommended for normal risk women. There are controversies as to whether screening should start at age 40, 45, or 50, whether it should be done every year or every 2 years. Quality of the image and quality of the radiologist does matter, and the importance, again, of a program of routine screening with image comparison. Clinical breast examination on a routine basis is a good idea when mammography screening is not available. We should all realize that screening, even good screening, will miss some disease that we wish we could find, especially among younger women with dense breasts. Screening will find some disease that does not need to be treated. There is overdiagnosis in breast cancer. Overdiagnosis is a special question for new 3D mammography technology. The TMIS trial in the United States is assessing how bad overdiagnosis is. And colon cancer. As noted earlier, stool blood testing has been shown in randomized trials to save lives. This requires 3 samples to be analyzed in a lab every year. Sigmoidoscopy done every 3 to 5 years has also been shown to save lives. To date, there are no randomized trials to confirm colonoscopy every 10 years, but it's widely accepted because of sigmoidoscopy that colonoscopy does save lives. One should note that if doing stool blood testing, a positive stool blood test, or if doing sigmoidoscopy, polyps found on sigmoidoscopy requires a colonoscopy to examine the entire colon. Colon screening is thought to reduce risk of death by at least 35% and risk of cancer through polypectomy by 20%. Colon screening is the least controversial of all screening tests. It saves lives when it can be linked with good treatment once diagnosed. Recently, stool DNA testing has become widely available. The test looks at certain DNA sequences in stool that suggest malignancy. Stool DNA testing is often now combined with stool blood testing. The currently available test has some specificity issues and results in a high number of false positives and colonoscopies that result. Cervix cancer. The Pap smear, testing for the presence of HPV DNA or HPV infection, visual inspection of the cervix. These are the three tests that are all used and all shown to benefit in terms of saving lives from cervical cancer. It's of interest that the first randomized trial in cervical cancer was completed this century, although we've been doing Pap smear screening for 60 years. The Pap test every 3 years, beginning at age 21 or within 3 years of starting sexual activity, is the norm in many countries. After 3 normal yearly smears, a smear every 3 years can be done. An abnormal screen can be followed up with HPV testing. Women aged 30 and over might consider HPV testing alone in lieu of the Pap test. Abnormal Pap smears or positive HPV tests should be followed by colposcopy and biopsy of suspicious lesions. Approximately 4,100 women will die of cervical cancer in the United States this year. A survey of medical history show that overwhelmingly the majority of that 4,100 women did not have any cervical screening test within 10 years prior to their diagnosis of cervical cancer. Lung cancer. The National Lung Screening Trial was conducted in the United States in the early 2000s. It randomized 54,000 people at high risk for lung cancer because of age, 55 and above, more than 30 pack years of smoking history, to spiral CT or sham chest X-ray. This was done in 30 major university hospitals in the United States. After 10 years, there was more than a 20% reduction in relative risk of death in the CT screened group versus those who got the chest X-ray. In this high-risk group, the benefit was 5.4 lives saved for every 2 people with a complication due to an invasive procedure and every 1 life lost prematurely due to a diagnostic procedure. Keep in mind the study was done in 30 of the best hospitals in the country. Results for low-dose CT screening may differ if adopted at other facilities, and the benefit-risk ratio may actually decrease. A number of respected organizations in the United States actually support that doctors and patients have a discussion about the benefits and risks of spiral CT for lung cancer screening and then make a decision if the patient has available to them high quality screening and treatment. Prostate cancer. A number of studies have shown the harms of prostate cancer screening. 2 out of the 11 studies have actually shown a mortality reduction. All 11 studies have some flaws. We generally do now accept that screening for prostate cancer does save some lives. The European study that showed that screening saved lives has been interpreted by the American Society for Clinical Oncology as the following. 1,000 men aged 55 to 69 screened regularly over a 12-year period. 100 will be diagnosed with prostate cancer. 4 will die of the disease. Because of our understanding of overdiagnosis, an increasing number of that 100 will be sent to observation and will never receive therapy in their lifetime. Of 1,000 men aged 55 to 69 who choose not to be screened over a 12-year period of time, 60 will be diagnosed with prostate cancer and 5 will die of the disease. 5 per 1,000 dying going to 4 per 1,000 is the 20% reduction in relative risk of death. Screening saves one life in 1,000 men screened regularly for 12 years, but at what cost? Of the 100 diagnosed through screening, 96 think they are the 1 in 1,000 whose life was saved. The American Urological Association has published some guidance. They say, given the uncertainty that PSA testing results in more benefit than harm, a thoughtful and broad approach to PSA screening is critical. Patients need to be informed of the risks and benefits of testing before it's undertaken. The risks of overdetection and overtreatment should be included in the discussion. Summing up, cancer screening can be beneficial, can also be harmful. It's often both, and only a good randomized trial can disclose the net benefit to the population, that is, the risk to benefit ratio. And we need to follow good science. This is just a picture of my institution, the Johns Hopkins Medical Institution. Thank you. It's been a privilege to talk to you today.